meeting, and I'd like to thank Enzo and the rest of the organizing committee for having me. You can see what Mark's been talking about all these years. So I'm going to talk about orientation techniques and graft opening techniques in DMEC. So I have no financial interest in anything I'll be discussing. Trypan blue and injectors are off-label. So my standard DMEC technique is what Mark was just showing. Graft preparation is now done at the eye bank with pre-stripped, pre-stamped, pre-stained, pre-loaded tissue that they do post-preparation validation on to make sure the endothelium is still healthy after it's been pre-loaded. Graft handling and delivery are done with the STRAIKO modified Jones tube injector. Graft unfolding and centration, I use no-touch tap techniques. Graft orientation is confirmed with S-stamped tissue. Graft support and adhesion, we use 20% SF6 gas, as first reported by Dr. Guell. Place an inferior PI to prevent pupillary block with that gas, and overstrip the host relative to the size of the graft. So here's a 1-week post-op. And you can see not my finest case, rather edematous cornea. You can see some graft separation there. And on OCT, why isn't this graft adhering? You can see the DMEC graft is upside down. That graft should be curving up this way. The endothelium is on the outside of the curve, and so this graft is curving the wrong direction. That's an upside down graft. So again, to look at the correct graft orientation on the left, the endo is on the outside of the scrolls, so it should be how it is on the left. It's easy to remember. Correct on the left, incorrect on the right, so you have either comedy or tragedy. So avoiding tragedy, that's our goal here. First way to avoid tragedy is using scroll-based techniques. These depend on the tissue scrolling as it's supposed to scroll. The first of these described as Musora's sign, which is very readily available. You just use a cannula, and as you can see in the upper left, frame A, put the cannula on top of the graft, go left and right. If the cannula disappears into the graft, you're right side up. If it does not, it's what's happening in frame C. You're upside down, and you just rubbed the endothelium with a metal tube. So you can also use slit lamp attachment on the microscope, which we found to be rather unwieldy. The Eidolon handheld slit beam is a little better, but I had trouble sometimes interpreting what I was seeing, and if there was advanced edema, it was very difficult. I have a YouTube video on the subject too. Scroll-based techniques, you can also use tangential illumination with a vitreoretinal light pipe. It helps to visualize the anterior segment if you turn off the microscope and use just the light pipe in very edematous cases, but it still can be difficult to interpret the graft position. OCT is another modality, but it is very expensive and rather cumbersome to use. So avoiding these upside-down DMEC grafts, the scroll-based techniques really depend on the tissue scrolling as it's supposed to, but sometimes, as depicted along the bottom, you get a graft that sort of does an S shape, or it does just a flat graft, and it's really hard to interpret what's going on, and these techniques just don't work. And in fact, our success with scroll-based techniques was not that hot. In our first 32 cases of our standardized DMEC technique, we had a 12.5% PGF. 3 out of 4 of those were due to upside-down grafts. And we thought they were right side up at the time of tissue elevation and surgery. This was among 3 different surgeons. Additional series have shown the same problem of upside-down grafts driving primary graft failure. So the ideal orientation technique should be independent of the shape of the tissue. You should be able to tell the orientation prior to elevation with air. It should have low trauma, and it should be very intuitive. And that's where I like the S-stamp graft. So the S-stamp has saved us a few times here. And Peter Veldman was a fellow of ours several years ago. And he did the laboratory validation work on this. You can see the pictures are depicting how the S-stamp is applied at Lions Vision Gift. And we found that it causes very minimal cell loss of less than 1% using vital dye staining, so it does not damage the endo when applied correctly. Then we followed that up with a clinical validation paper and showed that our source of primary graft failure had been eliminated. Didn't impact the cell loss at all, and graft attachment rates remained the same. So no negatives, all positives with our S-stamp experience. So orientation technique, the best thing really is to start with the tissue right side up. And Dr. Tan's technique is excellent for that. But what I like to do is the Veldman-Venn technique. If you think about the graft that you see on the left as a Venn diagram, the way it overlaps, look at the number 1, it forms a V. You want that V on top. And if you twist the injector clockwise and that moves with you, moves in the same direction, then it's right side up. If it moves the opposite direction, you're looking down through the graft, and the graft is upside down. So what that looks like in the tube, if that's the graft, you want the V shape on top, and when you inject, you'll have the correct graft orientation and you'll avoid tragedy. Oh, good, good. So I always insert the injector bevel down into the anterior chamber and then rotate it. After it's inserted, then I rotate to get that V on top and inject. Inserting bevel down helps maintain the anterior chamber better. So gently inject, very staccato plunger depressions. You don't want to overinflate the anterior chamber because then the graft will come flying back out. I'm decompressing the anterior chamber with some forceps there to make sure I don't overinflate the anterior chamber. Then I'm blocking the incision with a cannula. And I can see that the graft is in a nice double scroll conformation. So the tapping, you tap on the cornea parallel to the graft. It generates a fluid wave that goes down along the iris plane and helps knock those scrolls open. And as I'm opening it, I'm also recentering it because I want it to open as centered as possible. So I'm always going back and forth between centering and opening. This graft is opening okay, but now it's in a taco conformation. So I have to stop and think, push with the blue arrow. It relatively deepens where the orange arrow is so it can open. Again, I'm using 2 cannulas to center, pushing with one and tapping with the other, and then centering. And I'll speak a little more to centering in just a bit. And after that's centered, then we'll lock it in with a gas bubble. And so maintain the eye in primary position is very important. If you tort the eye up or down, it can decenter the graft when you inject, and you want to inject very centrally, right in the middle of the graft to lock it in. And you can see as I zoom in, you can see little areas of endothelial cell damage, but not bad. Overall, it looks very healthy. Post-op day 5, this was my first preloaded case, and the graft was excellently clear, and her vision was already really recovering quickly. So sometimes the graft is upside down and you need to roll it over. The idea here is to inject not straight at the graft because that'll just jam it into the anterior chamber angle. Aim along the iris or corneal plane to create a circular fluid to fold the graft over. And you want the anterior chamber deeper when you do that, not overly shallow. And here's another video showing same idea here. Inject along the iris plane to roll the graft over, just short little bursts, with the graft central and in a deeper anterior chamber. Here I'm using the Fogla cannula that Rajesh Fogla developed. It jets fluid out the sides of the tip to help open a graft. Unfortunately, I opened it upside down. You can see the backwards S, otherwise I may not have realized that was upside down. And so I'm going to make sure the chamber is deep enough that there's room for the graft to roll over and inject along the iris plane. It flips it over, and I'll show that again in slow motion. And it just rolls the graft over. Now, if I had injected straight at the graft, it would have just pinned the graft into the angle. And now it proceeds as a normal case. Okay, so centering a graft. So here I'm sweeping, and it generates a fluid force that goes forward, backward, and that doesn't work. Now, tapping gets the graft to shimmy across. So with the SICSSO, you tend to sweep. That doesn't really work with DMEC. Now, most of my surgeries, I use 2 cannulas. The following cannula keeps the graft from bouncing backwards, and the leading cannula helps to tap it into position. And so using 2 cannulas to open it is very helpful. The only time that doesn't work is if you need to apply pressure on the equator to shallow the AC. So tapping, it was just going forward, backward. With 2 cannulas, I'm able to walk the graft into position. I'm going to stop there because it was going to open into the angle, and so I'll recenter it before I open it. It's just as important to be centered as it is to be open. And now we just lock that in place with some gas. So some final tips. Very important to try to inject right side up. I like Dr. Tan's technique for that with holding onto it or using the Venn diagram type technique. Modulating the anterior chamber depth. When you're trying to open a graft, it's very important to pay attention to the AC depth. If it's too deep, if it's a hyper deep chamber, the tapping is ineffective and the graft just continues to scroll back up on itself. If it's too flat, there's no room for the graft to open, so it's really modulating the depth. If something's not working, probably check your anterior chamber depth. Maintain centration. People ask me, it's a common question, what do I do when I get stuck in the angle? My main reply is don't go in the angle. Just keep centering it, don't open it into the angle. Work slow and methodically, you have time, there's no rush with DMEC. So develop a plan if you see sort of a double scroll, but then prepare to adapt if it turns into something else like a taco or it's upside down. And just like my mentor. I'd like to thank my wife, Megan, and our twin girls, Caroline and Julia, for letting me come here and do all this work and come to this nice conference. Thank you.